to continue to do. So to start off, everybody take out your phones. We're going to do something called a Kahoot, and we're going to do like a little pre-poll here. So you're going to go to this website that it's going to pull up for you. You're going to enter the game pin, and then you can enter your name. You could be anonymous. Make it work appropriate if you make something up, Bill. There's no right or wrong answer, so you're going to just kind of answer with your gut instinct, and then we'll talk about them and come full circle towards the end.
Should I specify a 2.0?
Yes. Did they give you a 2.0 already? Jen swear.
I'm Jen Square.
I like 2.0.
I didn't enter your address. Was that you?
That was me.
Oh,
Yeah.
Oh, there was the Wi-Fi.
I don't know.
You guys get to pick those cool characters, or do they just
You can jinx.
Might be a duck.
Everybody in? We win on anybody? There you go. Good? All right. So answer. So answer with whatever your gut tells you to start. Most of them are 10 seconds, some of them are going to be 20. It's a lot of pressure. Questions on the screen and then just answer it on your phone.
Getting ready.
Thanks, look at it. Nancy Hunter.
What was the 6-digit code? I'm sorry.
298032.
I hate the answer.
Oh, almost 50-50 there.
It's a simple answer.
Bill, you're new bands.
I hate that answer. I know it and I hate it.
That's good. Last one. All right, so all of these we will circle back to and we will get more clarity. So really quick, things that we're going to talk about and cover today are reviewing compliant documentation standards. The overarching theme is going to be what's considered skilled and medically necessary services. Identify key components of our notes. Apply strategies, though, to help you more effectively and efficiently support skilled and medically necessary services in your documentation. Review our commonly used CPT codes and their appropriate usage. Review our ICP-10s, discuss proper documentation and evaluation complexities. I know this can get confusing. Common payer complaints, and then kind of reviewing some different myths and blunders that we typically do with billing and documentation. So for something to be considered compliant documentation, it ultimately has to be defensible documentation. So there's kind of a couple things that fall within that. The first one is payment justification. So that's where we get either paid or we get denials. A lot of us kind of think that our daily notes are just to document what we do and then just shift it to billing and then kind of take care of the rest. But there's a lot of in between that we really need to fill in the gaps on. Communication, so it's kind of like our communication vehicle between us and the other medical providers and insurance payers. So each document and each note should really be able to stand alone. And you should be able to paint a good clinical picture of how that patient started, where they're going, and what you anticipate their prognosis looking like. Anybody who reads that note should be able to kind of decipher that. And then it's also important, in our clinics, like if Kristen Cohen comes to cover for us, those clinics who have other therapists who might be co-treating patients, they should be able to accurately replicate what treatments are on a day-to-day basis. And then legal protection and risk mitigation. So this is something that, thankfully we don't have to deal with this on a frequent basis, but it's something that is important. So all of our documentation should really be done in a way in which we would hope that it can stand up in court. So this is what could protect us against possible lawsuits and audits. There's some cases where sometimes we are called as expert witnesses, and we have to rely on how we documented that note and those encounters. So if we can't really rely on our memory, so it's something that 3 to 5 years down the line, our recall of those events isn't going to be considered supportive evidence, and we need to really rely on the document itself. So this is kind of a common statement that people use in reference to this: is if it is not documented, it was not done, and if it was documented, it was done. So you really want to make sure, this happens a lot sometimes when we import notes. We might stop manual therapy, but we kind of forget because we're rushing to take out the manual therapy portion of our objective. And it shows that we put our hands on that patient and that we did something, and we maybe actually didn't, and that could come down the line to circle back to us. What we're going to cover a lot today is going to be proving that the services that we're providing are medically necessary and that they warrant skilled intervention. So what ultimately So what do you guys consider to be medically necessary? How would you define it? Without
Close your eyes and answer.
It's a term. Go ahead, Mike. I see you.
Person can't do it on their own. They need our judgment for making load adjustments, answering questions, cueing on proper technique, just things that they couldn't do by themselves at the gym.
Yeah. So that's a very good starting point for it. So, medically necessary is something that we see a lot of times, listed in their benefits or in referral management. It says they get 60 visits based on medical necessity, but do we actually know what that really entails? So all of our documentation should really factor in everything that necessitates our services. So it requires our knowledge, our clinical judgment, and then our actual skill set. So part of how we could document that is showing that we provided evidence-based practice and applicable standards of care. So that's something where in the initial evaluation, the assessment or the daily note, you can notate that you're treating the patient based on an established plan of care, based on evidence-based recommendation, the clinical practice guideline recommendations. And then kind of the question we should always be asking ourselves is, were the treatments provided absolutely necessary? And they can't be being provided at the patient's convenience. So we get a lot of those patients who they say they want to keep coming because they won't do their exercises at home and they know that they'll do them if they come to us 2 days a week. Insurance isn't gonna pay for that. And then we saw this a lot too with COVID, like some patients didn't feel comfortable maybe going to the gym, so they're like, oh, well, my insurance is gonna keep paying for it, I'd rather just come here. That's not still considered medically necessary. So it's something that we need to have a good understanding of in how we choose to treat our patients, but then also how we can relay and educate our patients on how they can utilize their services so that we're not unethically overutilizing physical therapy. So ways that you can think about this when you're treating your patients and documenting is, does your patient have a problem and does it impact their function? So we really need to include on our evaluations, our progress notes, and our daily notes in between, what they're experiencing is relating to their function. So sometimes on our evals, we kind of just say like a patient has pain or a patient had surgery, and there's no specific notations of what their current limitations are, and that's something that insurance looks for, and always needs to tie back to that. So this is actually a definition. We tried to pull a lot of examples from insurance providers, so this is actually one here where in order to be medically necessary, services must be of a level of complexity such that the services can only be safely and effectively be provided essentially by us. So then that leads into what's considered skilled services. So this is where we have to demonstrate our expertise and our knowledge that what we're doing is necessary and that it was provided during that episode of care. And then this is really important to kind of think about too. So this again was pulled from, I think this was either Medicare or Anthem, but a patient's diagnosis or prognosis is never the sole factor in deciding that a service is or is not skilled or necessary. So for a patient, like when we document a patient that had a total knee replacement, we can't just say that they had a total knee replacement and they require our services. There are some patients who might come in and they have full range of motion and they're actually doing really well. They're like, yeah, I just went golfing the other day. So do they necessarily need to see us 2 times a week and have services provided for us that might provide for them that might not necessarily be necessary or skilled? So when you document, you really have to demonstrate why you. So this is where you're going to be demonstrating what you did for that patient and how that's benefiting them. You have to document your clinical decision making. Why did you choose the interventions that you did? And are there any complications or comorbidities that are impacting how you're choosing to treat that patient and impacting your decision making? And you really have to use your brain and not your hands. So it's not necessarily where we just document the actual techniques or the skills that we're doing, but we have to defend why we're doing it. And then that all ties back into value. So it's all going to kind of come full circle here. So the treatment needs to be valuable to our patient and cause an effect. So we have to think about, are they benefiting from it? Is there something that's changing? So and it needs to be measurable, quantifiable. And sometimes that's hard with patients because they kind of are like, yeah, it's kind of getting better. I don't really know. You know, we have patients who aren't necessarily good historians or provide subjective reports, but things that you can think about are, did their pain levels change? Did they demonstrate a measured change in range of motion? Are they able to do something now that maybe a week ago or 20 minutes prior to some type of intervention that you provided that they're able to do now? We have to reference how is the patient making progress towards goals. So this is actually something that a lot of insurance providers use as some of their criteria to approve more visits, and how they can review our services and determine if they're justified and medically necessary. So our goals really need to relate to function. There's actually one specific insurance provider who leads AIM who actually says it can't be pain related, it has to tie back to function. And that's how they determine how many visits they're going to continue to provide as well. And then demonstrate a discharge plan. So our goal is to get is what we can do for the patient, not necessarily what we're doing to them to make them feel better. So we want to be able to get them to a point where they can self-manage their symptoms, where they're independent with home programs for long-term outcomes. We need to reflect that in our notes, so there should be references to establishing a home program and how they're progressing towards that, reflecting on a discharge plan over upcoming visits. Some patients are seen for like 10 visits and then they're just discharged on the 10th visit, and there's like no notation of how they're progressing in an upcoming discharge plan. And then justification. So this is kind of another way of looking at how services can be considered medically necessary. Do problems still exist that can be helped by therapy? So sometimes we'll get patients who they come into for us for like neck pain. They're like, oh, my knee hurts too, my low back hurts. If they met their goals and they progressed appropriately with that initial diagnosis, does that mean that we can continue to treat them? Not necessarily. And we have to think about, is it all being done in a reasonable amount of time? So have they been coming to us for 2 months and they're not getting better and they just want to keep coming, we have to think through, are we providing something to them that's showing benefit and that's justified. We talked about is the types as far as our skills, but then the frequency and duration of therapy, is that appropriate? So this is where we kind of think about the MD scripts. Our doctors have, their MAs kind of generically put like 3 times a week for 4 weeks, and it's a rotator cuff repair, and they're definitely going to probably be with us for more than 4 weeks. So this doesn't mean that you just kind of generically make everybody 12-week plans of care. It doesn't mean, though, that you necessarily do 3 times a week for 4 weeks if you don't think in your clinical judgment that's what's appropriate. So when we do our evaluations, we establish our own plan of care. And you have to think in terms of if that time is appropriate based on what the patient needs and what you're going to provide to them. And then this is another criteria that they look for in determining medical necessity, is if that patient's expected rehab potential or progress is shown, is it insignificant in relation to the time that they've been with us. So if a patient is with us, they kind of have benchmarks that they look at. If a patient is with us for a long period of time and they're not showing appropriate progression, in an audit they can reverse reimbursement, it can result in some denials. So those are things to think about as well. If no more problems exist and we don't think we can directly help that, that's when we want to plan for a discharge. So some examples of this, this is kind of our bread and butter here, where we create a plan and a program that requires our skill and our services. And the provision of that program needs to be reflected in data notes as well. So if a patient is coming to us for several weeks, we should be making notations of changing either load, repetitions, exercises themselves, and then that should be reflected in the daily notes as well, and along with like a home program, like I said before. The amount of cues that we're giving them is considered our skills, services, and demonstrating medical necessity. And the medical record must clearly describe the patient's condition before, during, and after. And this is from Medicare. So that's where we want to look at what their current level of function was when they came to us, what we're doing to make them better, and then where they're hopefully going to be by the end of the services that we provide. So kind of more importantly, so that we can understand it a little bit better maybe, is what is considered not medically necessary. So a prescribed program that can be performed by the patient individually or with the assistance of a caregiver. So sometimes we might have patients who they kind of just come in, they know where everything is, and they just do it themselves, and we're kind of just like, hi, I get to see you, and that's the end of it, which hopefully isn't happening very often, but it does happen. That's not considered medically necessary. If the patient is getting to that point, they probably don't need to continue to be seen by us. The services should not be repetitive, palliative, or simply reinforcing previously learned skills or maintaining function. So they also look here at, and a lot of insurances are looking at our flow sheets. So the flow sheet should reflect changes in exercises, changes in load, something that's demonstrating that we're providing something to the patient that they can't get on their own. And ongoing repetitive exercises that don't demonstrate the need for hands-on involvement. So if you look at a flow sheet and they've been doing the same thing for several weeks, something needs to change, and we're not probably providing skill at that point. This is from AIM. This kind of gets tough because a lot of times we get post-op patients who maybe want to get back to lacrosse or basketball, soccer, and insurance does not consider that medically necessary. So it's something to think about when you're developing plans of care, frequency and duration. Is it something that the patient can maybe do a program follow-up in a month and you progress things appropriately? You have to get a little bit creative in your documentation there. They also don't consider improving running distance medically necessary or skilled services as well. And then you guys can read through that, it's kind of long there, but this is an example of a denial of payment letter from Medicare. So the patient showed progress, but the document failed to show the need for skilled services. So it shows that no new therapeutic interventions were provided, and the documentation didn't reflect the need for skilled services to be provided for that patient. So next, Jen is going to talk about how you can tie this all into different components of our
I just wanted to add one thing. So a lot of times, especially the new therapists, you're like, oh, I have my flow sheet. A lot of the denials aren't happening at the time of service. It's more so down the road when they're doing an audit and they go back and they review 800, 1,000 charts, and they're like, well, this one we're not going to pay, this one we're not going to pay. So it'll be like 5 years after the fact that they're going to say, hey, Connecticut Orthopedic Sports Rehab, you guys owe us, $125,000 because that 190 visits or whatever weren't deemed medically necessary. So it's not live, it's usually after the fact.
Yeah. No, that's a good addition, Eddie, because you don't always see the direct result of it in the short term. All right, so we're going to just go through each section of our notes and then how we can provide documentation that we're providing skilled, medically necessary and valued services. The first place that we're going to start doing that is right in our initial evaluation, right in the subjective. If we remember that medical necessity is that the patient has a problem and it impacts their function, you can start to establish that right away in your brief history of injury. So let the patient tell you why they're medically necessary. Let them give you kind of the rundown of what they've been through so far with this condition, and they'll, if you let them talk, guide them in the right way, but if you let them talk, they'll tell you what's going on. They'll tell you what their problems are, how they developed. Then you can, just dig a little bit deeper. What sorts of treatments have you already had for this problem? And just kind of get a pattern that way. And you can start, that's going to all start to play, and you'll see as we get down all the way into our medical, our eval complexities, is some of how they've already been responding to treatments thus far. And this is a really great way to hand this patient over to another clinician, and they don't have to ask the patient repetitive questions, and they have a really good picture what the patient has been through. I don't know, especially in larger clinics, I don't know, and for our PTAs, I've heard this a bunch of times from patients. I don't want to go over this again. I already told so-and-so this. I've already relived this, how many times. They see 3 or 4 different clinicians, now they're telling their story over and over again. If you have a really solid subjective in your eval, then you don't really need to go through that with the patient. Just take a quick peek at it, and then they really feel confident that every provider that they're seeing knows what's going on and is kind of on the same page. So that's where documentation is important in communicating with each other. So that's especially important in your PT-PTA teams. If you go on vacation, when Kristen Cohen covers, you want to make sure that patient feels confident that whoever is putting their hands on them or giving them advice or giving them exercises or progression has a really good idea of what's going on with them, and can really feel confident, and that helps to build that patient PT relationship too. Then in the follow-ups, so this is in your daily notes. You want to, in your subjective, again, we're providing necessity and value by how did the patient present today? How did they respond to our previous treatment? Just simply saying, putting in quotes, I feel good today, is not really giving us any information. If I pick up a note and I'm like, oh, patient feels good. Well, they did all this new stuff at their last visit, or they just had their eval and they're doing a home program. I have no idea how their status has changed in the last 2 days, 4 days, 8 days, however long it's been since their last visit. So just kind of touching base on that. And then that starts to create that pattern of symptoms. Are they progressing? It's super easy to see that if you look at daily note, daily note, daily note. I responded well to this, now I can do this. I was sore for 5 days after the last visit, maybe you overdosed your exercise. They had a big win, they had a big setback. These are all things that we can document super easily in 1 or 2 sentences in our subjective, and that really supports kind of continued necessity and value. Every so often it's going to be that the patient presents without, new complaint. You're seeing them twice a week. They are in a post-op period where their status really isn't going to change for 2 to 4 weeks, but you can't document that every time. If you keep doing that, then now all of a sudden you're going 6 visits without having any sign of progress from the patient, and any good information about how the patient is responding to your program. And that's the information that you collect from the patient in the beginning, during their subjective, when you're walking in with them, when you're getting them on the bike, when you're getting them on our bike, when you're getting them set up on heat, whatever it is, that information is going to give you what you need to set up your session for the day. And that's how you're providing that skilled and valued service. Now you're assessing how they're presenting for that day. Am I doing the same stuff we did last time? Do I have to dial it back? Can I ramp it up? Where are we missing the mark? And that's all the stuff that you're going to get right off the bat when they first show up and when we first start talking to them. So I'm just going to have some examples here of maybe how to super easily structure your notes. Super easy template. So brief history of injury. So this is on your eval.
patient is so-and-so, arrives for this, they had an onset of symptoms, they went to see the doctor, they went to the ER, their, you know, brother said, you know, you really should go see my guy, like whatever it is. Summarize what they've already had as far as treatment, and why they're presenting to you today. Where did they come from the doctor? Did they come from the ER? Were they self-referral? So here's an example for a post-op. Again, we're looking at how this problem progressed in the pre-surgery phase, and then how it escalated to the point where they were having surgery. And then, like, if it's a knee, they had home care. They stayed overnight at the hospital. They had home care. They were discharged on whatever day. Now they come in for therapy. Your coworker picks that up, and they're like, "Oh, I know everything that I need to know about this patient as far as how this injury all progressed." It's really important in patients that have like chronic pain conditions, of people who have like some more yellow flags where there's a little bit more psychosocial component. They don't want to relive their long, probably chronic history of their problem. So the less questions that you have to ask as a new clinician, the better, and that will help to establish some trust.
So then, objective is pretty straightforward. There's some components though that we really want to emphasize that need to be included. So this is where we identify what we did and what we're billing for. We need to have specifics on location, duration, and the rationale for that. So in our objectives, we can't just say that we did greater than 8 minutes of Therex to improve range of motion strength. It needs to tie into what is the rationale for that CPT code, and then also how it ties into their impairments and their goals. So you need to tie it into maybe their goal to be able to walk community distances without an assistive device, reciprocally navigate stairs, be able to, you know, wash their hair, those types of things need to be identified in the objective. We all know about recording the total treatment time and one-on-one time. And then, like we've been talking about, the flow sheets need to reflect that all exercises were performed. It needs to be legible, which might be hard for some people. And then have specific dosage and volume listed. So you can't just kind of have check marks in there. You need to really have specifics of what's being done. And that helps prove our necessity, skill, justification, and value. And then what else needs to be included? So assessment and management time is billable time. So it's what are using our skills and our clinical judgment in order to provide interventions. So that could look like assessing a patient prior to performing a hands-on intervention, assessing the patient's response to the intervention. You know, sometimes they do something and then they say it hurts. We go, we take a look at it, we see what maybe could have been impacting it. Instructing, educating, and advice giving for home care, home exercise program. So the time that we're using to either establish a home program, have discussions with them, and educate them maybe on like a walking program or a cycling program for like our NeoWave patients or our bike patients, all of that is considered billable time, and it needs to be documented within the objective of under what your intent is. So a lot of times it probably will fall under like Therex. If you're instructing on like a balance and safety program, that could fall under neuro-re-ed, but that is valuable time that you're providing to that patient, and you really should, you know, kind of get value back for the services that you're providing and using your knowledge. Really quick, physical findings. So it's important to have this in the notes so that you can show any progress that's objective and quantifiable and measurable. So this should really just include test results, but they need to be measurable. Range of motion, outcome measures, pain levels, strength. And then in your assessment, you can provide the clinical reasoning for maybe why that's happening or provide the justification for it. In some random chart audits, these are some examples that we found that fall under that are put under physical findings that aren't probably physical findings. So, you know, pain with squatting, that's not really measurable. That could be considered a patient's response to treatment, which would fall under assessment. Less pain, that's very vague. Hamstring stiffness, so how can you quantify that? Is that demonstrated with a straight leg raise, the hamstring 90 test? Good knee mobility, very broad, motivated towards goals. That's good to notate, but it probably doesn't belong in the physical findings section. And pain with all activity, that's also probably a patient's response to treatment that belongs more in the assessment. So it's good to show progress in terms of that are measurable, and that's where you should include that in the physical findings section. So Jen's going to talk about the assessment, which is probably the most important part of the note.
Yeah, my favorite. So long. All right, so we'll talk about the assessment starting with the initial eval. In our initial evals, I know you guys have all written one or two probably, so you're kind of familiar with it. We have our kind of daily section where we have our objective that kind of outlines our treatment for the day, and then there's an assessment portion there. What you want to put in your assessment portion there is the same type of thing you would put in a daily note assessment. So that's not your overarching assessment of the patient or of the eval or of the plan of care. It's how they responded that day. So did you provide any treatments, any manual techniques or any other sort of treatment? How did they respond to that? Did you give an exercise program? How did they respond to that? How did they perform it? Do they have any questions? How did you answer them? Did you give them any education regarding self-management, incision care, blah, blah, blah. All that stuff is going into your assessment the same way it would on your everyday daily note. So that's going to be the first part. So that's going to be in like, you know, patient IE was performed to establish plan of care. Then you have greater than 8 minutes of their X because you gave an exercise program, and then you talk about how they responded to their exercise program. This is where I put a lot of my patient education stuff. So whether I'm going over prognosis, expectations, if it's post-op, their plan for rehab, those sorts of things, incision care, those sorts of things, I'll outline in my assessment. And then again, when someone grabs my eval because I'm on vacation after I eval them, or they go to a different office, or Kristen Cohen comes in or whatever, she can look at that and be like, okay, this is the education that Jen provided, so I'm going to continue this narrative as we go. Instead of kind of everyone using their own bias and their own kind of clinical, expertise to give different information. We might not all be thinking the same things, using the same words, but if you read my assessment, you'll see how I talk to that patient, what my plans are, and what I expect. And then you can mimic that. And then that patient, again, is getting the same information from all of their providers. And that continues to build trust. The more the patients trust us, the better they get. And the better they respond to therapy. The more they come to their visits, the more they adhere with our programs. So that's super important. It seems like something that's easily looked over, but that aspect of communication with patients is kind of our bread and butter. Yeah, we can prescribe exercise. Yeah, we know manual therapy techniques. But the way that we talk to and communicate with our patients helps them get through whether it's a long journey of chronic pain or a scary process after an ACL or anything like that. Now when we go down into the assessment, so now we're assessing the person and we're establishing our plan of care. It has to include the medical and the PT diagnosis, a summary of the functional limitations and participation restrictions, summary of physical impairments, and a statement of PT benefit, which ends up kind of now going in again and playing down into our establishment of the complexity of the eval. So this is something that I would use. I probably took this out of one of my notes, maybe a little more psychosocial here. But if you read through this a little bit, you can kind of see that that if someone else grabbed this patient was a little bit emotional during her eval. Someone else grabbed this patient from me and was not really aware of that, and not kind of aware of there being some underlying things going on. Might be a little bit tougher to gain trust with that patient. You might think she was like a little bit cold, a little bit distant, but you're able to read this and be like, okay, she's having some other things going on outside of this problem, so maybe we need to make sure that we're going a little bit less aggressive on why aren't you adhering to this, and why haven't you followed your program, and realize that this person has other stuff going on, and be a little bit softer in your communication with them. So, another one, this is a post-op. Now this patient came in with a blister on her incision, so we had to talk about incision care and some stuff like that. I contacted the surgeon to get her in to be seen sooner than her follow-up. So these are all the types of things that you're putting right into your daily note, into your eval in that objective section, that daily section. So you can kind of read through these. This is the template that I use for myself. All of my assessments look like this. It kind of automates the process for me, so all I have to do is plug in the right words for the right patient. I've been doing, this is how I've written them for 10 years, so my fingers just kind of blow right through. It's super easy for me. But it has all the stuff that we need. The patient presents with signs and symptoms of whatever, which can be a PT diagnosis, but it can also be a medical diagnosis depending on how they're presenting. Currently, the patient complains of functional limitations, participation restrictions, secondary to physical impairments, and then yellow flags if they're in there. Patient will benefit from skill PT to address, and blah blah blah. So all the same kind of template for me, and a lot of it ends up sounding the same. Everyone kind of has the same functional limitations, participation restrictions, all kind of being pretty automated. So this is an example of one from one of my evals. So you can kind of read through that. You see rotator cuff dysfunction, non-dominant left upper extremity. Someone grabs this and they have a pretty good idea of what they're complaining of. And for this person, actually, they were wanting to avoid surgery. So then that's also good information for the next treating clinician that that person's goal. So maybe that they're not really interested in getting back to perfect, but they're getting back to good enough so they don't have to go through surgery. A little bit for a post-op, I like to say how far out they are from their procedure. It's super outlined right there instead of having to go all the way back up to the subjective portion and then do math, because that's hard. So, sorry, something like that. Again, now your post-op's going to be a little bit longer because they probably have a few more functional limitations and participation restrictions. All right, so now we're going to a follow-up visit. Again, this is a great spot that you're going to establish necessity, skill, value, and justification for your services. So as we talked about earlier in the subjective, you're talking about how they responded to the previous sessions. Now you're talking about how they responded to today. Most of the time they responded pretty well because we're pretty good at picking good sessions and then modifying them as needed if they're having a hard time with anything. Special consideration here is workers' comp. You want to make your assessments relate back to work function as often as possible, or as appropriate. If they're post-op and they're not going back to work anytime soon, maybe you're not saying, oh yeah, we're doing this lifting thing because they're going to have to lift 100 pounds when they get back to work. But as you start to progress through with post-ops getting closer to work, then you definitely want to make sure that you document that. So this is where we're outlining and really showing our clinical decision making. So just some things that can be included to create a really good, strong assessment. You don't need all of them for every session, but some things that you can include. You need to include your statement of tolerance, and that's going to include any adverse effects or reactions to any of your treatments. That's going to go into every daily note. But then you're going to use your interpretation of your subjective and objective information throughout the session. So what they said when they came in, how they are progressing through their program for the day. And then you can outline why you progressed, regressed, modified, provided cueing, provided an internal constraint, an external constraint. How did you set up the environment for that person to exercise or to follow your treatment for that day? You can hypothesize why they presented a certain way. If they came in with increased pain, you can say the increased pain might have been due to the fact they went for a 5-mile walk and they hadn't walked more than 3 minutes since their surgery. Like those sorts of things are going to go into your assessment. It's going to help you to account for any complicating factors for the patient coming in for that day. Maybe they weren't able to do something because they have some other concurrent problem that limited them. Maybe you're seeing them for a total knee, but their back is hurting, they can't lay supine that day. It's going to really modify your treatment, and so that's something to be documented. You can also there put in your response to their program overall. If they're progressing the way that you expect. They're not progressing the way that you expect. You would expect them to be at this range of motion by now, whatever it is. And then any education that you provide to the patient will go in there. Good place to comment on any goals that they achieved, any goals that they're continuing to work towards, if maybe their goals have changed or anything like that. And then you want to continue to outline how their deficits impact their function. So why is it a problem that they have decreased range of motion? Why is it a problem that they have decreased strength? So it's a constant reassessment of progress towards their goals. So that you can pull one or two of those things from those categories in each assessment and have an assessment that's not repetitive and establishes that necessity and skill and value and justification in every note. Another thing for workers' comp I like to include is like a readiness for return to work. So whether the patient expresses that they're ready, whether they hit a milestone that you're like, hey, they can do this now. So even if they can't go back full duty. All right, so now we're looking at our assessment and our progress notes. It's going to look a lot like our evaluation. But you wanna make sure that you're making a summary of their progress with treatment thus far, both positive, or that's where you put your positives, and then continued functional limitations, participation restrictions, continued physical impairments, and statement of continued PT benefit. So it's really gonna look very similar to your initial evaluation, except in the beginning, instead of saying they present with this, you're gonna say they made whatever progress, and that's demonstrated by increased range of motion, increased strength, and then outlines maybe some of the goals they hit. So just some examples, and then a discharge note, which is gonna be obviously very similar to your progress note, where you're just gonna, instead of a statement of PT benefit, you're gonna state why they're appropriate for discharge. And the reason that they're appropriate for discharge could be that they're no longer demonstrating measurable progress, they're no longer appropriate for continued care. Again, that's, not everybody needs therapy all the time. Then just kind of a brief statement on goals. They should be realistic for your established time frame. So when, it's patients' expectation to achieve their goals, it should always be good. If you're writing goals that you don't think they can achieve, you should be writing different goals. The goal is to have them achieve the goals that you write in the time frame that you pick. So things you want to take into in consideration are the expected tissue healing time. Maybe if it's a post-op and they have a protocol and they're not allowed to lift their arm for 6 weeks, then maybe in 6 weeks their goal isn't to have full active range of motion because they're not gonna. So that's not, not realistic. And then this is where your clinical experience and your is going to come into play for how you expect people to kind of progress, how you have seen people progress with similar conditions. And then, of course, you're going to take into account the patient's goals and values. So what are the things that they want to achieve? And then, again, you're kind of just establishing what time frame you think that they're going to be able to achieve those. So whether they have a big overarching goal that they're going to achieve in 12 weeks, but you're going to write, they're going to see the doc in 4 weeks or 6 weeks, and you're going to write a progress note around that time. Then you cut that goal in half or in a third or whatever, and maybe that's not their end goal, but that's a goal that they're going to meet in a reasonable time frame. And then in your progress note, you want to make sure that you're identifying any complicating factors that cause them not to reach their goals in the event that you didn't write good goals and they don't meet them all. It could be that you don't get as many visits as you expect. It could be that they went on vacation and they missed 2 out of the 4 weeks of therapy that you expected. They had a total knee and then they ended up having a manipulation. All sorts of things like that, a death in a family, all sorts of things like that that complicate your achievement of their goals. And then you're going to update them. They can carry over if you think that now they are going to be able to meet them for whatever reason why they didn't. You think they've overcome that barrier and now they're going to. Or it might be just a progression. So maybe it was one goal was that they would ascend 1 flight of stairs, but they have 3 at home. So now the next goal is going to be that they're going to be able to ascend 3 flights of stairs. Okay, so this is, now we're going on to the plan. So this is a little template that I use for my plan, for my daily notes. Plan's pretty self-explanatory and straightforward. Do you plan to try something new at the next visit? Do you want to assess something specific at the next visit? Did you try a new manual technique or add a new exercise and you want to make sure that you assess how they responded to it? Are you planning to hold PT because they're going on vacation, because they have something coming up? Just so that, again, you're like, if they fall off the face of the earth, you're like, oh, why didn't they come back? They went on vacation and they never rescheduled when they got back, or something like that. Just so you kind of have a really clear picture of how you're moving forward in your plan. This is a place where you can extend the plan of care end date for certain things, whether it's, they're going to see the doctor in 2 more visits and you're going to write a progress note then, instead of writing 2 in a week's time, you extend the plan of care end date to coincide with the MD follow-up. Or again, same thing if they miss their plan of care for some reason. And from visit to visit, the plan is going to be pretty similar because your plan is going to mostly be the same as you're moving forward. But this is just another way that we're communicating with our fellow therapists, right? So if I do a new manual technique and I want to assess for a specific thing, but I'm not seeing the patient next, then the next therapist should be able to look and be like, oh, I need to make sure that I ask this because that's what the last therapist thought we were going to do. And that allows us to have a nice continuity of care and a continuity of documentation. Also, in your plan, you can start to paint that picture towards discharge. So whether it's patient plan to continue for 3 to 4 additional visits, assess readiness for discharge at that time, anything like that. So again, someone else grabs that note and they're like, okay, this person's really kind of winding down, and starting to have those discharge conversations with your patients as well. So some examples. All right, ICD-10. This was a fun thing to learn back when they finally decided to have ICD-10. I have some of this knowledge in my brain, but not a ton of it, so I'm going to read a little bit more off my notes than I have been, so I apologize for that. Just the general code format. First 3 characters identify the category of the diagnosis. We'll talk a little bit more about that. The second 3 characters identify the etiology, anatomic site, severity, or other details. And then the 7th character is an extension, so you'll notice that not all of the codes that we use have a 7th character. So 7 characters is always going to be a letter, and that identifies the phase of the encounter for a traumatic injury. So whether it's the initial encounter, subsequent encounter, or the sequelae. Most often, we're going to be a subsequent encounter, because that means that the patient saw another provider for this problem already. So unless we have a patient coming in direct access, they sprain their ankle, and then they walk upstairs and like, hey, I just sprained my ankle, that would probably be one of the only times that it's an initial encounter. Otherwise, we're going to be billing subsequent encounter, but I'm still not really sure how sequela works, so good luck with trying to figure that out. I've never used it. And then the fracture codes can be super confusing. Don't assume that the fracture code that the physician picked is correct, because the physician didn't pick it, their MA did, and they probably didn't actually read through all the options. So you might see that a code that says that it's a non-union, but it's actually progressing correctly, and it's just the wrong 7th character was selected. And I'll say this probably a few times, but when in doubt, use icd10data.com. I can give you guys that, but it's just a very comprehensive list of all of the codes, and then you type in the thing that you want, and it'll tell you what the code is. And then it'll give you codes surrounding it, so if you're not sure that that's 100% the correct code, you'll get the codes before and above and below it, and it will help you to pick the right one. So we're going to the first 3 characters here. These are our categories. Our M codes are the ones we're going to see the most. Those are disorders of the joints, the muscles, and soft tissue. S codes are injury, poisoning, and other consequences of external causes. That's going to be a 7-digit code because, like I said, it's going to need a phase of encounter modifier. Z codes are mostly our post-op codes, and then some special considerations. So in M25, you're going to have things like M25.3, which is joint instability. So that's 4 codes. 1, 2, 5, 3. That's 4 digits. The 5th digit is going to tell you the body part. So if it's 1, it's shoulder. If it's 2, it's elbow. 6, it's knee. And then the 6th code is going to give you the laterality. If it's 1, it's right. If it's 2, it's left. So the things that fall under M25 are instability, pain, range of motion limitation, and that's pretty much it. Oh, and effusion. Pretty much it for the ones that we're using regularly. M62 is muscle disorders. Most often, this is going to be used for disuse atrophy. I really only use M62 category for disuse atrophy. There are a few other things that don't really fall under our scope, so we're not going to see a lot of those. And if you're concerned, just go to icd10data.com. They'll tell you all about it. But then it's going to follow the same thing. So M62.5 is going to be disuse atrophy, so that's 4 digits. The 5th digit is going to be the body region. So 1 is shoulder, 2 is elbow, 6 is knee. And then, again, laterality, 1 is right, 2 is left. Then M79 is going to be your soft tissue disorders. This is going to be muscle types of pain or pain in the limb. So if you have, a calf strain, it's not really knee pain, it's not ankle pain, you can use M79. And that's going to be M79.6. And then 7 is lower leg, and 1 or 2 is right or left. Again, the S codes we're thinking of traumas, so this is going to be like a traumatic rotator cuff is going to come under here, but if you have a non-traumatic one, it's probably going to, I think, the M75s, which we don't use a ton, so I didn't really talk about those. Then some of our special considerations, R26.2 versus R26.9, that's difficulty in walking. R26.2 is related to the musculoskeletal system as a reason, is an etiology of gait dysfunction, versus 26.9, which is actually from the nervous system. So that's going to be more of like a difficulty walking due to like MS or a stroke or something like that. So 26.2 is the more appropriate code to use most often in our setting. I see a lot of people use M62.81 as a weakness code. The thing about it is not specific to a particular body region. It's actually weakness of multiple body regions. So the more correct code to be there would be, like I talked about before, M62.5, then the body region and the side. That comes up as like atrophy. So it's disuse atrophy is going to be included in that, which is going to be kind of where we can categorize most of the strength deficits that we're seeing. There is a new codes in 23 for back weakness. So typically I think people are like looking up the truncal weakness or something like that, which again ends up being really not the most appropriate code. So back weakness is going to be M62.5A, which is 5 digits, and then the 6th digit is going to specify the spinal region. So I'm not exactly sure what they are, but cervical, thoracic, thoracolumbar, lumbar, and then lumbosacral. And then for surgical aftercare, we're using Z47 is the category, versus using Z98. You'll see Z98 like for a spinal fusion or something like that, but that's really just a history of that surgery. It's not the aftercare for that surgery. So if we're seeing someone after for aftercare, Z47 is the correct category to use. For joint replacements, we're using Z47.1, which is the after code, and then for joint replacement, and then the joint replacement specific code, which is Z96.6, and then the body part and the side. So you're using both of those together, because one means that the joint replacement was done, and one means that we're treating them for the aftercare for that joint replacement. I think we've gotten an email recently about coding low back pain, so M54.50, with some other diagnosis, typically like a lumbar strain, and that we can't bill those two things together. The reason for that is because it's an excludes one, which means that two conditions cannot occur together. So think about trying to code for a condition that can be either congenital or acquired, and trying to bill those at the same time. They can't have a congenital scoliosis and an acquired scoliosis. It's one or the other. So the same thing here, M54.5 is non-specific low back pain. So if you then specify where the back pain came from, those things can't occur together. So if you know where the back pain came from is more specific. So whether you're going to use facet arthritis or lumbar strain or something like that, you can't also use M54.5 because that is a code of unspecified or non-specific low back pain. Excludes 2 means that the two conditions can occur together. So one code does not represent the other code. So if you want to bill, we're talking about a calf strain, but they're also having ankle pain, you can bill for lower leg pain, and you can also bill for ankle pain because they don't include one another. And the final thing is Greenway is not your friend in choosing codes. If you go through, you can put in one code, the number, and you can get 10 different descriptions of that code. And just because the description is different doesn't mean the code is different, because the insurance companies are looking at the numbers. So if you are unsure of which code to use ICD-10data.com, or just Google it really, and you'll be able to find the correct code. Any questions about that? That's super dense information, but no.
Anybody have questions on anything else before we go into the sample question? A lot of doctors don't understand like the medical necessity part, and they think that just because they write a script, we can keep seeing patients. So I think it's something that we just have to approach with them. There's going to be tough patients with like maybe workers' comp where they keep sending them back and they can't go back to their job and we're kind of in a tough spot. But with some doctors, if you just kind of say, listen, this patient's gonna get better, I've seen them for X amount of weeks, X amount of visits, right? Oh, well, the patient just asked if they can keep going, so I just wrote a script. Like, they don't understand. So that's sometimes conversations that we have to have with them too, but I know it can get tricky. So we're gonna go through our most commonly billed CPT codes here. So Therax is kind of the one that we most generically use, and there's some codes that may be more appropriate, which we're gonna break down a little bit more for you too. So therapeutic activities, we've probably been using that more in recent years, and a lot of what we do falls under that. We just need to get more creative with how we document and how we bill. Neuro-Re-Ed manual, gait training we're gonna talk about a little bit too, because that can also be utilized maybe a little bit more than we use it, and then we're gonna go through initial evaluation and reevaluations. So the definition of Therax itself is to develop strength, muscle endurance, power, range of motion, and flexibility. So that includes active range of motion, active assisted range of motion, passive range of motion, and passive stretching. So that's really important. A lot of people put those under manual therapy, and it's not considered manual therapy. It's addressing range of motion flexibility, which is going to fall under Therax.
And also, it's something that the patient can do themselves. So me doing a passive hamstring stretch or giving them a strap to do a passive hamstring stretch is the same thing. So because I'm not providing a skilled service, because I'm not having a direct impact on the tissue, I'm just holding their leg. They can hold their own leg.
There's been, there's one denial in particular in recent year or so that I have seen because it was being billed incorrectly under manual therapy and it was considered something the patient could independently do. So that's something to be aware of. We have to switch it into Therax and it's not considered, or it shouldn't be billable under manual therapy. And then our isometric, isotonic, isokinetic exercises to improve aerobic or cardiopulmonary endurance and how that relates to maybe their goal of being able to navigate community distances. Time spent on assessment, management, and patient education will fall probably under therapeutic exercise. And we should avoid using the term warm-up. So warm-up isn't considered skill service. We have to think about what is the intent of what we're doing. So we have some examples on the next slide here of how we can document this. So like in our note where it says treatment began with, you could delete that. You don't necessarily have to have that here, have that there. But if you're going to put the bike or the UBE, it shouldn't have a follow-up statement that says for a warm-up. So it should be what you're trying to also target is, are you trying to improve their cardiorespiratory fitness? Are you trying to improve range of motion so that they can bend their knee more to get in or out of the car? Those are some things that you should think of. You can use it as a warm-up, it just shouldn't be considered billable time. So that shouldn't fall under your Therax time. And then another option down here as far as what you're doing in order to make that skilled. So are you trying to establish a biking program for the patient for long-term management? And you're assessing like maybe their RP or their tolerance to it and how you can modify that activity for them so that they can replicate it on their own. That's considered skilled. An example for how to document skilled passive range of motion and how it would fall under Therax. So if it's a patient who maybe it's like a Dr. Klauser status post one day, rotator cuff repair, and you can only do
15 minutes ago.
yeah, exactly.
Just woke up.
Literally just came off the table. This is the way that you could document it so that it demonstrates why they need you to be performing that activity or performing that intervention and how it falls under Therax there. This is another example that's kind of like a plug and chug blurb as far as it's Therax, what you're targeting and why you're targeting. So this is what we were talking about before where it needs to tie into their impairments and tie into their goals. And then at the end there you can include that that's where the passive range of motion was performed as well. Any questions on that? Some people's minds are like blown when they see they can't put passive range of motion under manual therapy anymore. So therapeutic activity. So this is something that we can probably use more. So if you're billing sometimes 2 units of Therax, chances are that some of those exercises are going to fall under therapeutic activity. We're just not thinking of it in those terms. So this is defined mostly as a dynamic functional activity to improve their functional performance. A good way to really remember this is think about tasks that are ending in ing. So carrying, lifting, squatting, lunging, transferring, reaching. Those are all things that are going to be a therapeutic activity. And then some questions to ask yourself here is it a functional activity will improve their performance and directly correlate to a functional task? And this is really important too, is more than one parameter being addressed. So for therapeutic exercise, some of the exercises might just be targeting strength. for therapeutic activity, you might be incorporating strength and coordination, and that's gonna make it more dynamic, which will fall under therapeutic activity. In your documentation, you really have to think, and in your billing, you have to really think about what your intent is. So are you doing a squat to make their quad stronger, or are you doing a squat so that they can get up and down from a chair easier? And then an example of how you can document that in your note. We tried to give you guys an example just so that you can kind of play around with words if you need to in order to make it more efficient for you. Neuro-rehab is pretty straightforward, so we're targeting proprioception, movement, balance, coordination, kinesthetic sense. Some examples that the CPT coding gives as far as what exercises are specifically fall under neuro-rehab there. And an example there, again, ties into a goal or a functional limitation that the patient may have, wanting to be able to ambulate on their own surfaces, community navigation. So manual therapy, so this is where we're targeting with loss of joint strength, mobility, range of motion, that's impacting function. So range of motion is included here, range of motion is also included on TheraX. But the examples of what's going to be addressing the range of motion are that's considered manual therapy, is mobilization, soft tissue, work, manual traction, and then just a reminder here that it's not considered manual. Another example of how you can document it. And here you have to be very specific about where you're doing it and what you're doing. So this goes back to using our documentation as communication, but also being able to be replicated between therapists and then tying back into the impairment. So you can't just say that you did joint moves. So it has to really be more defined as far as what you did and where you did it. And then make sure that you're including your time in the beginning of those statements under objectives. So gait training, this isn't just like when we're showing the patient how to maybe use their crutches or go down to one crutch. This can also fall under stair training. When they're transitioning maybe from a weight bearing status, if they're going from no weight bearing to partial weight bearing or to a touch weight bearing, if we're spending time doing that with them, we're showing them how to use crutches for stairs. Those types of things can fall under gait training. If you're using specific gait training techniques, like sometimes with our geriatric population, maybe they are coming in with balance deficits and that's their primary reason for coming to you, and you're doing maybe dynamic gait training with obstacles and things like that, that would fall under gait training. So we have some examples of what to consider and then how to document it there. So are you assessing their gait cycle? Are you instructing them on how to maybe improve their knee flexion in their swing phase of gait? Are you trying to get them, cueing them to have better heel strike for extension? And then down here is an example of maybe how you're using reactive feedback to simulate a community environment where the variables aren't necessarily as controlled. And that's how you're promoting more dynamic gait training, where you can also build your gait training as well, versus just maybe a neuro-rehab or a TheraX. So the self-care and home management code. This should rarely be used, if ever. This is more specifically if you're showing them how to utilize some type of compensatory strategy at home in order to perform ADLs at home. So your HEPs and your home instruction should not fall under this. That should go under the code that describes the focus of that. So if we're trying to do balance, that's going to fall under neuro-rehab. If it's a walking program or general range of motion strength program, that should fall under TheraX. It shouldn't be billed under this. So this is like if you're showing them how to maybe use a sock aid, that's going to fall under the self-care home management, but that should rarely be used. Does that answer your question, Mike? Yeah. So Jen's going to go through the initial evaluation codes.
Okay, so the initial evaluation codes now, because there are 3, there's a service-based code, which means that it doesn't matter how long it takes. There are some rough guidelines as far as the complexity for the duration of the eval, but you can do an eval in 15 minutes. It's still the same code. And it's going to include the patient history, objective measures, assessment, their presentation, and plan for rehab, so we all know that. And then there's a low, moderate, and high as far as tiered complexity, and then those 4 factors determine the complexity that we choose, and that's going to determine which code we select. 97, whatever, 161. Look at there, there. So we're going to go through establishing complexity. So that's like your barriers to rehab, kind of towards the end of your note. For the first part is personal factors and comorbidities. These are just some examples of things that will fall under your personal factors and comorbidities. The thing is that it's not enough just to say that they have these things, like this person is old. Like that's not a good enough. That's not a good enough documentation as to how their age impacts their plan of care, and then how their disability will be experienced by the patient. So that's how you're going to document why their age or the fact that they have diabetes, how that's going to impact your plan of care and how that's going to impact their progress in their recovery with their current problem. So just listing out, we'll talk a little bit more about this in a second, but just listing out those factors is not enough to establish an appropriate selection of maybe a moderate or a high complexity as far as their personal factors and comorbidities. The next is the examination of body systems. This is our bread and butter because this is all the stuff that we assess and evaluate. It's going to include body structures and functions, activity limitations, and participation restrictions. So all of these things. When I document this in my notes, I'll just say to see the assessment, because if you go back to our assessment, if you write it in that way where you're outlining their activity limitations, participation restrictions, and their physical impairments, all of this information is outlined in the assessment, so you don't have to rewrite it. You just kind of say, look at my assessment, and that's where all the information is. Next is their clinical presentation, so stable, evolving, or unstable. And then I just have some examples as to why you're going to pick each different one. So evolving would be that they started with an initial complaint and then they developed something new since the time of the initial complaint, but before they came to see you. Maybe their initial complaint resolved before they came to see you. They had surgery, so you expect their pain and dysfunction to vary. They just got hurt, so you expect their pain and dysfunction to vary in your early phases of recovery. And maybe the nature of their condition lends itself to having variable levels of tissue irritability. So that would maybe be like they have a chronic episodic low back pain. They have flare-ups that occur. You know, there's any potential that that's going to occur during your plan of care. It's going to impact how you treat them. Then you have your unstable or unpredictable characteristics. And this is we don't see a whole lot of these, but you want to be aware of them when they do come across. These are sometimes your zebras. Maybe they have some red flag-ish type symptoms, and you want to make sure that you're closely monitoring them because you're not sure how they're going to respond to the plan or respond to therapy, and you want to make sure that you're ready to kind of refer them out as appropriate. But some reasons that you might select this is you can't establish a pattern of symptoms during the clinical exam, you can't complete the clinical exam, their subjective reports are inconsistent with their objective findings, so that makes it pretty hard to establish an appropriate plan of care because maybe you're not exactly sure what's going on and you're not exactly sure how they're going to present each day. If they're inconsistent, they refuse to move or refuse to let you touch them, and you can't actually establish any level of activity tolerance or tissue tolerance. Their signs and symptoms are not consistent with a musculoskeletal etiology, so that's that red flag thing that I was talking about. If you're kind of suspicious that they don't have a musculoskeletal condition, you're going to want to make sure you're on high alert for watching how those symptoms progress, but you're also not sure how they're going to progress, so you want to be ready to refer out. And then this again goes back to establishing a good history of how they've been treated so far. And maybe they haven't responded as you would expect to previous intervention, and that's gonna make it harder for you to kind of gauge how they're gonna respond to your intervention. And then the last one is your clinical decision making. So that's kind of all of those things wrapped up into one. How is your plan of care or the patient's progress impacted by the other three categories? And then you're gonna establish that by documenting it in each individual section. So this is just an example of how I would document someone with a moderate clinical or an evaluation complexity. So the person has scoliosis, probably going to continue to have episodic pain that isn't really predictable. So that's going to impact our progress. See the assessment for all the other stuff. And then this person has had some baseline level of pain that has been progressively worsening over the past year. So that's showing that the clinical presentation is evolving. And then this is just the each code 97161, what each piece has to hit in order to hit low complexity, moderate complexity, high complexity. How many categories from each section. All right, then we're going to go on to reeval. So this is also a service-based code, and it reports on your progress towards the initial evaluation. So it's going to include an examination and then a revised plan of care. So with your reeval, you're not billing for a reeval like we talked about for every progress note. It should only be if there's a significant change in status compared with their initial evaluation that would require you to change their plan of care for some reason. So that would be like if you're seeing a total knee and they go and have manipulation, you would do a progress note that would be billed as a reeval. So anytime they're going from like pre-op to post-op is a good time to bill a reeval. If they have some sort of injury, maybe a fall or something like that, and now they've had a setback with the thing that they're seeing you for. The key here is that a reeval only can be billed when you're referring to their initial complaint. So because now the complexities are tiered and the reeval is not, the reeval only refers back to the initial evaluation. So if they are seeing you for a problem and then they fall and then they have another problem, you have to do an initial evaluation on that new problem. You can then treat them together, but each new complaint needs its own initial evaluation to establish the complexity of that problem. We used to just be able to write a progress note, add the new problem in, and then no big deal. But now you need a new evaluation to evaluate any new conditions that you haven't evaluated or established in the initial plan of care.
So if we have someone that's like pre-op and we know they're getting surgery and they're gonna come back post-op, should we not discharge them
Yeah, correct.
and then do a re-eval?
Yep, and so like
not another evaluation.
Yep, so like
What if
it-
I've already discharged her?
Well-
I know she's coming.
The discharges are kind of informal.
Okay.
When this person comes back, you can in fact just write a
Do a
re-eval.
re-eval. Okay.
Yeah.
Okay.
And I'll do that sometimes if I'm seeing someone and then maybe a month or two goes by and they like have a recurrence and they're coming back for the same problem. I'll do a re-eval because am I going to charge their insurance company a second evaluation within 2 or 3
For the
months for the same thing? No, I'm
Okay.
going to bill it as a
Okay.
re-eval. So I'll probably do an initial eval because I haven't seen them in a while, like to that degree of thoroughness. But I'll bill for a re-eval because it's really not a new eval; it's the same thing.
Right. So you're not doing a progress note like you would write a new.
So it depends. It depends on how long it's been since I've seen them.
Okay.
But for a pre to post-op, I do a progress note.
Okay. So when she comes back post-op ACL, I'm gonna write.
A progress note and bill it as a re-eval.
Okay.
Yep. So what are we billing for? We have service-based codes and time-based codes. Service-based codes are evals and then most of our modalities. And then time-based codes are all our procedural interventions that Britt just outlined. And that includes all the things you have to do to deliver an intervention. So that includes the assessment of why you're delivering that intervention and then any setup time. You just want to make sure that your documentation supports all of those things. We're going to talk really quickly about selection of units. So for commercial players, it's confusing because everything's about 8. For commercial payers, we have the rule of 8s, which is time-based codes in 15-minute increments that are applied separately to each unique service. So one unit of one service ranges from 8 to 15 minutes. 2 units of unique services starts at 16 minutes. So that means 8 of one and 8 of the other equals 16. If I want to bill 2 units of the same code, I have to achieve a full 15 minutes of the first unit of that code because one code goes from 8 to 15 minutes. And then in order to achieve that second unit of the same code, I have to do another 8, which is 23. But if I do 2 separate units, 2 different unique CPTs, I can do 16 minutes, can be 2 codes. Does that make sense? So the same code can only be billed twice if you're greater than 23 minutes, but unique codes can be billed after 16, 8 of each. For Medicare, so the difference there, right, is that we are looking at each code separately for commercial payers. For Medicare, we're looking at the total treatment time together. So what you're gonna do is you're gonna take your 1-to-1 treatment time as listed, and then you're gonna be able to figure out how many units that you can bill based on the 8-minute rule. It's very similar, it's the same thing. It's each unit is 8 to 15 minutes. In order to bill another unit, you have to add 8 onto 15. So you have to add 8 minutes to the maximum number of time for each selection.
And this is only Medicare B, so our Aetna Medicares, our Connecticut Medicares don't fall under this, that's a commercial payer.
So instead of looking at the time for each individual service, you're looking at the time for the total treatment and then dividing to achieve some number of CPTs, the max number of CPT codes. Yeah, that's it. That's all I have to say about that. Does that make sense? Do you understand the difference? Yes, everyone? All right. So now we have some billing examples. Wait, do we have more questions? Do we have more questions? I'm going to read through this example here, and I'm just going to kind of outline some things. So here we have 20 minutes in one example and 39 minutes in the second example, right? But each can only be billed for 1 unit of each service, right? So we have 10 minutes of Therax and 10 minutes of neuromuscular. Each can be billed once because it's greater than 8 minutes. But if I have 22 minutes of Therax and 17 minutes of neuro, I still can only bill 1 unit of each because I haven't achieved that threshold of 23 minutes for either service. So, conversely, if this is a if this is a commercial payer, then that's all that we can bill is those 2 units. But if it's Medicare, 22 and 17, that's 39 minutes. So I should be able to bill for 3 units. Does that make sense?
Because you're billing for total time.
Because I'm billing for total time. Correct. So in Medicare, you can use the extra time and combine it together because you're looking at total treatment time. Versus a commercial payer, you're looking at each service individually. So each service, because they haven't crossed the threshold of being 2 units, can only be billed as 1 each. Does that make sense? Now, if that were a commercial payer, I would probably want to bill more units, right? I'd want to bill at least 3 units. So maybe I'm looking at my therapeutic exercise and trying to figure out what actually is therapeutic activity. Are we doing sit to stands to strengthen their quads, or are we doing it to make them better at getting off the toilet? Alright, so Medicare B patient arrives for treatment 2 weeks after a total knee. It includes these things. How many units can we bill? How many total units can we bill? Anyone?
3.
Great. And what units are we billing?
Therax.
How many?
2.
Okay. And?
Therax.
Okay.
Transfer training.
Right, so that's 3 units.
Yeah.
Okay. But we also, 2 units of Therax is only going to be reimbursed at 1.5 times instead of 2 times. Once you start to bill 2 units of the same code, the second unit is only billed at half. Or is only reimbursed, at half. So, to diversify a little bit, what we can do is, because we have 40 minutes, is we can use some rollovers. And we can take, we don't need 12 minutes of Therax, we only need 8. So I can take those 4 minutes and add them to my gait training, and I can bill 1 of Therax, 1 of Theract, and 1 of gait. Does that make sense? Blue Cross patient, 4 weeks after rotator cuff repair. This is the treatment that we give. How many units can we bill?
units.
What, 3 units?
Therex. Neuro.
You can do theirs twice.
Can we do Therex twice?
Wouldn't active assisted and passive do Therex?
Sure. But now if we bill Therex twice,
Oh,
we
then
are
it's
only getting
1.5.
reimbursed at 1.5. If we're simulating self-care tasks, why wouldn't we bill that as Theract? Right? So Theract, what's the, you said 3 units, what's the other?
Neuro.
Neuro? Why aren't we billing for
Go
tens?
for tens.
Was that a unit? It's not timed.
It's not timed. Service-based code, we did it, we get to bill for it. It's
Yes,
four,
we send
it's
it out.
4
A
units.
unit or no?
Hmm?
Considered a unit?
Service-based, as soon as you
Okay.
put it on them.
So then to circle back to some of the things we talked about, any questions on the billing? So that's something that we'll probably get into some habits with, that we learn new ways to approach it. So to circle back to some of the things in the beginning.
I have a question about
Yeah,
the
go
Medicare. So, say you're doing something Therex related for like 4 sessions. Isn't there some rule with Medicare per fee where it's not skills? So if you're not teaching them like a new skill in that Therex unit, you can't bill for that time, or am I just thinking that up?
All of our CPs skill, right? You, yeah.
The codes are not skilled
Right.
versus unskilled. It's your documentation that establishes skill versus non-skill.
Okay, so even if it's something that it's like routine based, that you could still, if it's something that you're not one-on-one treating with them, like going over.
Did you establish the program? Teach them the program, progress, regress, assess their response to the program? It's all skill.
Okay.
Just because you establish it, you create it, you check in with them, you maybe modify it for the day, you hand it off to an aide, that's your program, that's your skill.
Okay.
You have to be able to see them and talk to them, you can't like send them home to do it, but if they're in your clinic and you've established their program, you've assessed their response to it, and you've modified it appropriately, it's skilled service.
And that goes back to the documentation where you want to make sure that you're providing some type of skill to them, even if it's a routine type of program. So for Medicare B, for a long time, we kind of thought that it was a progress note every 10 visits or 30 days, whichever came first. It's actually only just 10 visits. Plan of cares can be established for up to 90 days. It shouldn't be longer than that, but that doesn't mean that generically everybody should be 90 days if that's not appropriate. They can be double booked if needed, you just need to modify that one-on-one time. So that's just where you need to be conscious of, if they're in a time slot as Medicare B, you just need to be aware of your one-on-one time with them. The frequency and duration does not necessarily need to match the MD script. A common thing that we tend to do is overuse certain codes. So insurances actually pay attention to which codes we bill, tend to bill more of. So if we're billing like 3 units of Therex repeatedly, that's going to get red flagged. So that's where we have to just get creative and really just justify the services that we're providing. Like, what we were saying for therapeutic activities and things like that, we're providing more to patients sometimes than just a generic Therex type of program. So really just justify the skill that you're providing and using your knowledge. We frequently sometimes can under-time the treatment session. So sometimes we're actually underbilling, and that can be somewhat considered unethical depending on how the insurance reimburses us, but it's also where you're just not advocating for the services that you're providing. And then we sometimes bill according to the 8-minute rule for commercial payers when it should actually be just for Medicare. So only Medicare B follows that 8-minute rule. Everybody else does those rule of 8s, which gets confusing just because of the 8. Any questions on those?
The Medicare is no longer 30 days, and when did that end?
I learned of this 2 days ago.
Just talking about justification of services, so I've seen sometimes in various clinics, like people put Theract to improve so-and-so, and then they'll put progressions noted that. Is that required, or can you just comment on your Theract in the assessment? So if I put Theract to improve, like transfer training, and then I put today, progressed, weighted ball to improve patient, like strength or safety with
That's
transfer.
appropriate for the assessment.
Yeah,
Okay.
that's a good question. You can include it up there too, but it should be notated somewhere. I think
It
it's.
saves
I
you time to not
typically
do
use
it both times,
Yeah,
right?
absolutely. So we have a lot of complaints about insurances. Apparently they have complaints about us, and these are some reasons for denial. So too many abbreviations that aren't necessarily medically appropriate. Our notes don't demonstrate skilled care, or they don't support medical necessity. And this is what Eddie was saying, where it's after the fact that they can go back and do audits on some of our charts, and if they don't deem that we supported it in our documentation, we lose reimbursement for that. We're not demonstrating progress, so we're not showing that the patient's either progressing towards their goal or that we're providing value with the services that we're providing. And repetitious daily notes showing no change in patient status. So really be careful when you're importing, make sure that the assessments don't stay the same, make sure that you're changing things.
And we do get audited. It's not an if. We continuously get audited. So.
Right, it's not always that big, like, dramatic Medicare audit. I think that there's probably, like, you know, when you get a denial that it's like, we only recommend this many treatments for this,
And what happens
this
is,
diagnosis.
you know, if after audits they deem that we're not providing medically necessary physical therapy, that's when we start to see that instead of Blue Cross Blue Shield giving us 8 visits, then they're going to change our care. They'll label us as a lower skilled provider and they'll give us 6. Or, you know, that's kind of how it works. So you get thrown into these buckets of what you're considered by the insurance companies, and that's so better documentation, better demonstration of skilled care is going to give us more visits off our initial evaluations because they trust what we're saying more than, I hate to say it like that, than if we're doing bad care or documenting bad care.
Any other questions, guys? I know we gave you a lot of information there. Go ahead.
Did you have any specific examples that you came across on an exact denial, and like what happened with that, and what were the consequences, and then also the complexities? How much are they valuing that as far as payment?
they haven't changed the payment model for the complexities yet.
So they're paying, are they?
They pay all evals the same so far. Since it's been established, they've been reimbursing evals all at the same amount.
No matter what the complexity?
Right.
For now.
For now.
Dot.
Right, exactly. Well, that when it was established, that was the intention, was that higher complexity to be reimbursed at a higher rate.
But it's not.
But I think that kind of was taking hold more in like inpatient settings because they were talking about like RVUs and stuff like that in skilled nursing facilities. So it has not carried over yet, but we've only been doing it for 5 years, right? So that's really not that long. They're collecting data and I think trying to establish what makes sense. And what was it?
As far as specific denials, so from our off department, our billing department, some specific ones were flow sheets. That insurances were looking for flow sheets if they were not in the chart and or showed skilled progressions or changes or they were too repetitive, that was resulting in reimbursement issues. Another one was the way we bill and document neuro-re-ed. So that was a code that was typically not being reimbursed because it was being documented, not demonstrating skilled services. So those are 2 examples. We tried to get as many examples as we could. So a lot of those are from insurance, like you saw that Medicare denial. That is an actual Medicare denial. As far as from within the company itself, that were specific examples. Those were 2 of the ones that popped up from our off and billing department.
And then any of the consequences that we have to pay back whatever they reimburse to us.
Which
Yeah, go
I've seen practices have to reimburse
Millions of dollars,
yeah.
yeah.
Which isn't a fun thing to deal with.
What are your thoughts on like preventing functional regression? Because we have in our clinic, I don't know about your clinics, but we have this group of Medicare patients that January 2nd, they are making their appointment because they know it renews. There's a lot of them that, are cognitively impaired. They probably are not capable of doing a home program on their own. So the verbiage I usually try to use in my justification is we're preventing functional regression, to kind of justify it. And I try not to string them along for too long, but what are your thoughts on that as a justification? Because they're not going to be able to progress really. I mean, they're
Right, yeah, no, I absolutely understand what you're saying. So there actually is some criteria that they use referring to maintenance programs. We didn't get into that too much because it can get a little bit complicated. So there's some references on here that refer to the CMS.gov website where they actually break down how the maintenance programs can work for Medicare. I don't know if you would think it would fall into that category. It does get tough. There are some criteria where it refers to preventing regression, but then they're going to burn through their visits very quickly.
I mean, I don't know if this is the right way to do it, but I typically revert to like some of the balance scales and timed up and goes, more stuff you do in like a acute care facilities to justify that they're at fall risk.
And if it's something where not much is changing, maybe week to week, maybe it's something where you give them a program, you have them follow up 30 days to reassess, progress,
And if
and
their
kind of structure that.
cognitive impairment is their biggest barrier, then they might not be appropriate for your setting.
Yeah, if they can't do it independently, I think. Those can get true.
You know, because we can kind of play that card a little bit. Like, we don't have balance, where we don't have parallel bars, we don't have certain things that maybe would make us better equipped to treat certain diagnoses, and maybe they're just not appropriate for our setting.
Not to get too far off topic, one thing I think to mention about denials, so I haven't seen a lot of denials, but KDO workers' comp, I have to like weekly scan in the flow sheet to show them their skilled care. So they actually check my flow sheet to look for progressions in 2 workers' comp cases I've had. I've only seen it KDO twice, I don't think they're a big
I
carrier.
haven't seen any.
But yeah, they actually
I'm
follow
sure
the
that'll
health
start.
department. I get an email every week, and now I
Yes.
just instinctively scan in the flow sheet and bring it up front. But
Workers' comp typically frequently asks for our notes, like weekly, they ask for them to be sent over. And it's really important that you're referring in your notes to, like Jen was saying, to their work tasks and how it relates to that too. Yeah, that's a very good point. Even more and more insurances are probably gonna start following suit with a lot of that.